Thank you for that kind introduction. Good morning, everyone. So when I received this invitation of unearthing the building blocks of institutional and individual research capacity in health sciences, I was a bit puzzled as to what to tell you, but I decided that I'm going to tell you a couple of things. So of course, I have the obligatory slide on the Uganda Cancer Institute, and I'm also going to tell you briefly about what has been done in the past, but also discuss the challenges of biomedical research in Uganda and in Africa in general, and then tell you about what we're doing as Cancer Institute to address some of these challenges and what the future outlook is for biomedical research in our setting. So the Uganda Cancer Institute was established in 1967, and it was established as a collaboration between Makerere University, Mulago Hospital, and the US National Cancer Institute. When the Uganda Cancer Institute was started, it was established as a cancer research center for pediatric cancers. And in 2016, because of different challenges, the Institute attained autonomy and was also designated as the East Africa Center of Excellence in cancer care research and training. As I'll show later, this had enormous benefits for the Institute. The Institute currently is located, of course, at Mulago, but we're also setting up 4 regional cancer centers in Gulu, in Bale, in Arua, and in Mbarara. And all these regional cancer centers have actually received funding. The Gulu Center has been completed, the construction, and we're now in the process of operationalizing this center. At Mulago, we have a comprehensive cancer center, so we have all departments of oncology, so medical oncology, radiation, we have surgical oncology, gynecological. Recently, we have also added nuclear medicine, as well as pediatric, palliative, as well as community cancer services. Our mandate is all things cancer, so cancer prevention, cancer treatment, cancer research, training, as well as follow-up. This is, again, historical. So part of what spurred the development of the Cancer Institute was the discovery of Burkitt's lymphoma, or the description of Burkitt's lymphoma. And what I'm showing are just images from the 1950s and 60s of 2 children with Burkitt's lymphoma at the Uganda Cancer Institute, but also the Burkitt's map that was done across Africa. And this is a nostalgic image of Mulago Hospital, and I put this because of the floods yesterday, that we had significant drainage in the 1970s, but also a beautiful structure to do research and training. And of course, this was the faculty in the medical school in the 1960s. So now, pivoting to cancer research in Africa, these are the current trends that we're seeing an increase in number of publications, and I angled my talk towards cancer research, largely because most of my experience is under cancer and virology, but it's really illustrative of the entire biomedical research field in Africa. So what we're seeing is that output in research is increasing. If you look at the trends from 2009 to about 2020, you can actually see a steady rise in number of publications in all fields. But of course, cancer is the most affected of all these, that the least number of publications is from oncology. So output is increasing, but most of these publications are collaborative publications. So you have a South and North collaboration. So you have a researcher from the US, the UK, Europe, and then an African researcher. And 67% of all the publications were from North Africa, but of this total, 48% were from Egypt. That's the total from Africa. Then from Sub-Saharan Africa, we have 19% coming from Nigeria alone, when you combine all the Sub-Saharan Africa countries. So what this shows is that, yes, there's some research in Africa, biomedical research, but it's predominated by 2 countries. That's Egypt, Egypt, Nigeria, and then South Africa comes a close third. So what are some of the challenges? And I outlined this, but I'll talk about each very briefly. So funding is actually the biggest challenge to biomedical research in Africa. We need funding to conduct the research. We need funding to build infrastructure, we need funding to train personnel, and without the funding, it then becomes challenging to actually conduct research. And as we'll see later, most of the funding for biomedical research in Africa is not from Africa. So we cannot set our own research agenda. We depend on who is paying the money. Infrastructure is a problem, and infrastructure is both research but also clinical infrastructure. It's difficult to do research when your patients are dying. So most of the time, these go hand in hand, that we need to improve clinical research, clinical care, if we're to actually address research challenges. Personnel is also a significant issue, that we have a paucity of highly trained personnel. I read a recent study that was saying that we only have about 2,000 PhDs in Uganda, and those are very few, because if you want to conduct high-class biomedical research, you need highly trained people. You need mentorship, and mentorship is not only for the research, but straight from training. If most of our universities have less than 35% staffing, the mentorship is a problem. And the few senior researchers that we have are actually working with non-Ugandan actors, non-African actors. Most of them have the North collaborations. So maybe what we call senior researchers here are also being mentored by the northern colleagues. But there's little mentorship of our colleagues here. Brain drain is also a big impact, that most of the people who train very highly leave the continent. But I think this is going to change with the recent intervention of Trump, that it's going to become difficult, for example, to go to the US. So hopefully we'll retain some of these here. We have issues of data management and mismanagement. And the team before has been talking about digitization in Chirudu and Naguru. These are examples of interventions that we need to do to assure that there's data quality, but also that the data is available to do research. I've already talked about access to care, that we need to improve the quality of care if we're to do good biomedical research. Research regulation, so UNCST, the local recs, and also National Drug Authority. Working with them is important to establish an environment that's conducive to research. And of course, public awareness. We need to talk to our people. We have encountered some of these challenges at the Cancer Institute, that when you tell people to come and enroll in a clinical trial, even a phase 3 clinical trial, everybody thinks this drug has never been tested, there's no efficacy, and therefore we cannot participate in this trial. It's until recently, when we have started to see success in clinical trials, that now patients are more eager or more willing to participate in clinical trials. Otherwise, when you say we have a clinical trial, it's like you've moved from the lab to the patient, but most of the trials we're doing are actually far advanced, and we know the efficacy of all these drugs. So at the Cancer Institute, we have done a number of interventions to actually address some of these challenges. And I'm going to present this in two parts, because some of these are actually dedicated to improving the quality of care to address the research challenges. And you'll agree with me that if your patients are dying, it's very difficult to actually conduct any research in that environment. So the first thing that we did at the Cancer Institute was, of course, infrastructure improvement, infrastructure development. We're also looking at clinical excellence. We have done personnel development. We have also enriched partnerships and collaborations. We have supported mentorship, and we have also built other support services that improve the ability to conduct research. And of course, funding and policies go hand in hand to support this. So regarding infrastructure development, when the UCA was established in 1967, it was established as an 18-bed hospital. So that was the Lymphoma Treatment Center, and then STC was added in 1969. But currently we're expanding to a 350-bed hospital, and that's the building in the left bottom. And then you saw we're building a dedicated research and training building. Actually, we're setting up 2 buildings that are dedicated to research and training. So that's the one in the left upper corner, as well as another that I'll show later. And then also basically improving all the infrastructure that supports care. If the care is conducted in a high class environment, it means that you're actually able to do research, you're following protocols, The standard of care you have at the Cancer Institute shouldn't be standard of care in the US in 1960. It should be a global standard of care for all these patients. And I'm sure if you've interacted with a REC and you're talking about standard of care here, they'll tell you you're giving this regimen that is for 1980 because that's the standard of care here, but you need to change and give the current standard of care. So what we have done first is building infrastructure at the Cancer Institute. And then, so this is the research and training building, which is at the top of the hill. This is fairly advanced, the construction, and this is supported by African Development Bank. It's research and training, but it has, as I'll show on the next slide, it has surgical services. So we had a paucity of, we had very few theaters, so we're building 4 new theaters in that building and a 12-bed ICU, including 6 beds that are dedicated to surgery. We have a training facility, we have a conference facility. We're building reference laboratories, but I've also created research spaces. So we have a research lab, we have sit-down spaces or touch-down spaces for researchers that come to do research at the Cancer Institute. And we're not looking at staff of the Cancer Institute alone, but also partnering with the university to see if there are PhD students or scholars who need space. We'll provide that space so that people can do research in a comfortable environment. And we've also created a clinical trials ward, including a clinical trials pharmacy, as well as a clinical trials clinic. So basically a floor dedicated to clinical trials. So we have outpatients, we have inpatients, and then we also have the pharmacy. This is the current state of the building. We are hoping that by end of this year or early next year, we'll be able to enter this building. And this is the inside, what it looks like. So the other thing that we have worked on as the Uganda Cancer Institute is what we call research core facilities. These are the other facilities that an individual will not need to establish, or that research is going to be expensive if one individual is going to establish, say, a biobank. So we have established these core facilities, we have established the lab, we have established the biobank to support researchers. And this is really the progress of our biobank. We currently have more than 10,000 tissues annotated. That's pathology alone. But overall, we have about 600,000 tissues that have been annotated and banked at the Cancer Institute. And this is a stepwise process. It's phased. We currently have 12 ultra-low temperature freezers. We want to expand to 25 within the next 5 years. So around 2028, which is our timeline, we want to be able to expand to about 20 ultra-low freezers for the biobank, the refrigerators, assorted fridges. We have 2 liquid nitrogen tanks at the institute, and we also want to expand this so that researchers actually have access to these facilities. We have also, the metallic slide storage cabinets. And the idea is that these resources are available to researchers. You develop your concept, you come to the Cancer Institute. The Cancer Institute is managing these resources. They are not managed by the researcher. Of course, we'll be charging a small fee to maintain these facilities. But the idea is that as a researcher, you don't need to set up these facilities yourself. If you want to do breast cancer research, the tissues are there. If you want laboratory equipment, it's there at the Cancer Institute, and you can use it. So we have set up microbiology, we have set up flow cytometry, we have also set up sequencing, we have set up PCR, and the idea is that these will actually support research. Now, these are in the research section, but we think that these facilities are also going to support clinical care. So we don't want to do world-class research and third-world clinical care. We want these 2 things to move hand in hand. And of course, we have also invested in bioinformatics as we are setting up the sequencing facility. Regarding personnel development, which is really a key component of any research, UCI, with support of African Development Bank, we have supported over 204 health workers. Now, our concept at the Cancer Institute is that every health worker we train is a research resource. So we don't train people that are specifically researchers, but we train our health workers, our staff, to such a high level that these health workers can also contribute to research. And of these, we have supported 12 PhD trainees and also 43 oncology fellows. And we also have 6 accredited fellowships, oncology fellowship training programs at the Cancer Institute. So medical oncology, gynecologic oncology, pediatric oncology and hematology, radiation oncology, urologic oncology, as well as head and neck surgical oncology. We're also providing our staff with protected research and training time. So most of our staff will have clinic duty for 3 days or 4 days a week. And then the extra time is supposed to be dedicated to research and teaching. And we've also revised our HR structure. So that's a human resource structure. And we have embedded research-specific positions. So we have clinicians. So a clinician can actually rise to a consultant or senior consultant in cancer research. That's embedded within our structure. Nurses can rise. All staff can actually be embedded within the structure and actually rise to the top. And the idea was that there are also people who are basically research scientists and also need to be employed and rise through the structure. If you're not a clinician in the past, it was difficult to work at the Cancer Institute, but we're changing this. Of course, we have also introduced positions for biobanking, for regulatory officers, biostatistics and epidemiology, cancer registration, immunologists, bioinformaticians, and all these are actually support staff. They support, except the first one, they support the entire institute to do research. So our research regulatory, our biostatisticians are to support people to actually do the applications, to develop their studies, and all this is actually supported by the institute to minimize the cost of research at the institute. And clinical excellence, I've already talked about this, that we want to offer world-class care, and these are some of the things that we have done. We're enhancing quality initiatives at the Cancer Institute, and recently also our lab was accredited by SANAS, but also doing other quality interventions to make sure that the clinical care does not lag behind research. And the example I would like to give is a clinical trial we are currently conducting at the Cancer Institute. It's a multi-site international clinical trial, and it's a breast cancer clinical trial. They are looking at PIK3CA mutations, but for first line, it is Phesgo, which is a drug that is pertuzumab and trastuzumab. It was registered in Uganda about 2 weeks ago. But the eligibility is somebody has to have been on that treatment for at least 6 cycles to benefit from these new drugs. So we negotiated with a pharmaceutical company that gave us this drug so that we actually take people through induction on this worldwide standard of care. Our standard of care has been inferior to what is being offered across the world. So we want to also move our clinical services to such a level that when we attract trials from outside Uganda, we're not affected by this issue of you offering 1980 standard of care. And we've also built partnerships and collaborations, and we're looking at both local and external partners. Of course, the Fred Hutch is our longest partner, and we also have other external universities. Now, what is happening here is that the landscape for partnerships has changed this year. Most of our partners have been American partners, but we're now trying to look out and engage other partners that are non-US because of the changes that have happened over the last couple of months. And we're also engaging pharmaceutical companies or pharmaceutical partners. We have a lot of pharma partners that are working with the Cancer Institute to advance research. And of course, the local universities. And I've put these local universities because each of our regional centers is actually going to be co-situated or co-located with a university. So Mbarara, we're going to have the Mbarara Regional Center. Gulu, we have Gulu. Busitema, we have the Mbale Center. And then Muni, we have the Arua Center. And the idea is that the facilities that we are constructing in those centers will advance both research and training for those universities. So we're building the infrastructure and the necessary facilities for research countrywide. And of course, mentorship. We have public engagements, we have weekly research in progress, and we also have conferences and to support staff. The image here is from the Makerere Medical Journal in 1966. You may not be able to read it, but it's an aid to pediatric history taking in simple Uganda. And why I put it here, it was the Department of Pediatrics trying to mentor the local, the undergraduate students on how to take history taking. And I hope these are things that we can continue doing to nurture the young population. Of course, funding is still a big problem. Like I mentioned, most of the funding is from high-income countries. Most of our research portfolio is either from pharma or from NIH. And usually also requires a senior non-Ugandan co-investigator. So for most of them, it's very difficult to find a Ugandan alone winning this grant. But as UCI, we are currently providing research funding for pilot grants, and we're also applying for institutional grants to support our staff. And then, of course, Ministry of Science and Technology has also provided research funding to the Cancer Institute that we're distributing to our staff to ensure that we have this. And funding is still our biggest challenge, partly because as a country, we're not prioritizing research. We're also working on data stewardship. We're establishing a national cancer registry, which is going to be a network that gets data from different regional registries. So the Kampala Cancer Registry, which is already in existence, Gulu in existence, and then 3 others that we're going to set up, all feeding into a national cancer registry to cover 35% of the population. And of course, we're also moving to electronic medical records so that our data is accessible and usable. I'm coming towards the end, but we're also having, of course, this research dissemination. I think I've talked about this already, but this is the same journal, 1966. So other interventions is regulation. So the Uganda Cancer Institute has an accredited research ethics committee. We have an institutional biosafety committee, and we work very closely with UNCST and NDA. And we're also partnering with the Ministry of Health on some interventions. The National Cancer Registry, we're working closely with the Ministry of Health. We have developed a research policy and research agenda that's locally relevant, and then also provide digital resources for our staff. So we have CT, which is for GCP and ethics training. We have EndNote, we have Hinari, we have Access Research for Life, Elsevier, and UpToDate, really to make resources accessible for our staff to do research. So over the past 5 years, we have seen a number of achievements. So in 2016, we had about 10 publications per year. So we're now averaging about 45 peer-reviewed publications per year. We currently have 15 multi-site clinical trials, and 8 of these are pharma-funded clinical trials. We have over 60 active research studies, and we're also awarding at least 20 pilot grants per year for our staff to be able to do research. And of course, we have established robust partnerships. We're improving our research infrastructure. We have research policy and research agenda, as well as a biennial research dissemination conference that we hold for our researchers to actually disseminate this research. So, what's the future outlook? Funding challenges are going to get worse. The biggest funder of biomedical research is the US. With the changing landscape, it may get more complicated. We also need more trained scientists. We need more infrastructure, but that makes it seem gloomy, but the future is bright. There's more interest in biomedical research in Africa. If you look at part of the reason why all these clinical trials, for example, are increasing is because of the need for diversity in these clinical trials, but also, of course, some of the infrastructure that we have put up. If you look at genomics, there's interest in the African genome, and there's also more African funding. So government of Uganda is actually also deliberately increasing research funding. So through Ministry of Science and Technology, and then the universities are now also getting their own dedicated research grants. This is our research outlook for the Cancer Institute. This is actually a cancer research and innovation facility, which is going to be constructed starting 2027. And this is at the location of the current Cancer Institute, so next to the Fred Hatch building. That is where STC is, the director's office are. This is where we are going to establish the Cancer Research and Innovation Facility. And the goal is that the lower UCI campus would be a research and training campus. And these are labs, offices, touchdown spaces, and really facilities to support biomedical research. And again, not for Cancer Institute, but really for the country. And this is just to show the location. The Innovation Center is really at the bottom left right-hand side corner in the bottom, and all this is infrastructure that the Cancer Institute is setting to build research capacity. So I've come back with the slide that I started with, catalyzing biomedical research in Africa. It's now not challenges, but what we need to do to catalyze biomedical research in Africa. We need to increase funding, we need to improve infrastructure, we need to undertake personnel development. And when you train people, you need to be able to absorb these people. You need to compensate them appropriately. We need to undertake mentorship. We also need to address the challenges of brain drain, data stewardship. We need to ensure excellence in clinical care. We need to have a robust regulatory framework for research. And of course, we need to engage with the public. We need to disseminate the research that we do. And dissemination is important because when we do research and we don't disseminate the research, nobody knows about the amazing discoveries that we have done. So we need more African journals. We need more networks where we can disseminate our data. And then, of course, we need to do more partnerships, more collaboration. And this is mostly for South-South collaboration. So Ugandans need to partner with Kenyans, need to partner within Sub-Saharan Africa.